For some of these, we like to have a focus on wellness, especially around learning what others are doing around the country related to health and wellness. So I'm really excited about our topic today. Before we get started, just a couple of housekeeping items as we are listening to our speakers today, which I will introduce here in just a moment. You are welcome to use the chat feature within Zoom. If you want to put a question in chat, we will either try to answer it live as we go, or there should be plenty of time for discussion at the end, and can get to all questions during that time as well. So feel free, as you think of a question throughout the presentations, to go ahead and stick that in chat, and we'll help moderate those and ensure we get your questions answered. For those of you who are attending today and would like a copy of the slides, those will be posted on the Employers Forum website. And if you have any colleagues who haven't been able to come today, we will have a recording of this session posted to the Employers Forum website as well. So look for those out there either later today or throughout the week. So again, feel free to share those with colleagues and other members of the forum that couldn't attend today. With that, I would like to go ahead and get started. Again, our topic today is more focused on health and wellness and what others are doing around the country, and I'm really excited to have several speakers here today. The Pittsburgh Business Group on Health, which is really a sister coalition to the Employers Forum, their president and CEO, Neil Goldfarb, has been leading a hypertension project in his community. And we are excited today to have him here to share his approach and what they've been doing through the Pittsburgh Business Group on Health. Hypertension is the leading cause of cardiovascular death in the world. And unfortunately, it can be fortunately, it can be managed. Unfortunately, sometimes it's not. And often there are no symptoms, and so it requires a really deliberate effort to help manage that. So I'd like to welcome several speakers today to talk about the project that Neil has been working on. Specifically, I'd like to welcome Michelle Bildner. She's a project manager for the non-infectious disease programs at the CDC Foundation. She's responsible for identifying and leveraging public-private partnerships for chronic disease health promotion. Also, Meg Guerin Calvert is a senior managing director at FTI Consulting in Washington, D.C., and the founding president of its Center for Healthcare Economics and Policy. She joins us with over 30 years of experience as an economist in both public and private sectors, in competition and regulatory policy, mergers, damages, class certification, intellectual property, and healthcare and other industries. And then Neil Goldfarb is president and CEO of the Greater Philadelphia Business Coalition on Health, and he brings together employers in southeastern Pennsylvania, Delaware, and southern New Jersey who are committed to improving the health of their employees and communities, and the quality and value of care delivered by the healthcare system. And they represent over 1.5 million covered lives nationally. So a huge number of lives. I'm really excited to learn a little bit more about the hypertension program that you all have been working on. And with that, I will turn it over to Michelle, who I believe is going to kick us off.
Yeah, thank you so much, Kristen. Welcome to our session for the next little less than 60 minutes or so, focused on addressing hypertension at work. We are really honored to be with all of you from the forum, as you refer to yourselves. So thanks for having us. This next slide is just a quick disclosure that this work has been supported by the Centers for Disease Control and Prevention through the CDC Foundation, and our comments are our own. And in the next slide, we'll give a little bit more intro time to our co-presenters when their sections kick off. But what I really wanted to share about Meg and Neil and business coalitions and groups on health is really that I could not have been doing this work with employers for the past going on 4 years without their support. GBPCH has been instrumental in this work, And so, as we hopefully continue to work on employer health throughout the nation, love to build more relationships with our coalition colleagues. So, again, thanks so much. And certainly, the economics behind the tools that we're going to share with you, there's no way we could have done this work without FTI. And so I think that really brings me to what I'd like to share about the CDC Foundation is that collaboration is truly a hallmark. And I see myself as a convener mostly, and then being able to use strategic thinking and skills to really work and be part of strategic implementation on projects. So not just sitting behind a funded, a mechanism, but really diving into the work. And on the next slide, we do hope that this objective is achieved today, that we're really helping encourage employers and anyone who supports them, stakeholders included, to really be proactive in identifying hypertension as a priority for improving health and well-being and reducing cost of care through these key tools and strategies for success. I think that this speaks to what Kristen was saying about really shifting to health and well-being. And as we were just chatting about a moment ago before everyone joined, and we'll talk about too, hypertension is preventable and controllable. So we really do hope we can get that message across today. And then next slide, we'll just kick it off with a little learning about hypertension, just some quick data points that are really impactful. We kept the data a little, I wouldn't say minimal, but really focused. Because hypertension, also known as high blood pressure, of course, is the most common health condition among US adults. And unfortunately, it does affect more workers than either diabetes and depression, as we're showing here on this slide. This is not to say that we shouldn't continue to address depression, diabetes, and other co-occurring or other chronic conditions, but that we wanted to elevate that hypertension really does have a high prevalence. I mentioned comorbidities and chronic diseases. Hypertension being one of them, also often co-occurs with other chronic conditions, and we see that at the national level. We see that chronic diseases affect 60% or 6 in 10 Americans, and 40% or 4 in 1 of Americans usually have 2 or more chronic conditions. And of course, hypertension is often one of those, and silent, as we've come to know it as. So we do want to make sure that that's clear, that it's not just one or the other, but it's a both and or a couple and. And when we get into the benefits guide, we'll also recall, that lifestyle modifications and behaviors can really help with all chronic conditions. On the next slide, we'll talk a little bit more about how hypertension has been measured and what the current standard is. We also know that hypertension is a direct driver for heart disease and stroke, and we'll talk about those leading causes of deaths in a moment as well. Clinicians do diagnose patients as having hypertension by looking at their systolic and diastolic readings. And current guidelines issued as recent as 2017 really define hypertension or high blood pressure as consistently at or above 130/80 millimeters of mercury. And of course, the systolic is that top number and diastolic is that bottom. So again, 130/80. The next slide, we'll talk about what this condition looks like in terms of treatment and intervention, along with control. So in the US, 30% of adult workers have hypertension. If we look at the full population, nearly 50% of US adults have hypertension. Of half of the population with hypertension, up to 80% need to treat that hypertension with medication and lifestyle intervention. So this isn't a condition that is only treatable through lifestyle modifications, but we do see about 80% which of course can affect how you plan for benefits and work with your PBM on treating and preventing and controlling hypertension. Of those diagnosed, even though we know that medication and lifestyle modification would really help intervene with hypertension and mitigate it, not even a quarter have hypertension controlled. So, what we're really seeing is a large proportion of the US population, as well as the workforce, with uncontrolled hypertension. So that is something that we want to elevate, that it is controllable and we have a big gap of control in the US. On the next slide, you can also see US data here from a couple of years of prevalence among adults. And what I wanted to point out about this, as well as the previous slide, is what we're seeing in national trends, you're likely seeing in your workforces. With hypertension, this map would look similar to diabetes. This map would look similar to obesity and other chronic conditions. We do see disparities in terms of geography, with the South, Southeast, and a bit of the Midwest having those high prevalence rates of hypertension as well as chronic diseases. And on the next slide, there is another health gap, really talking about the fact that this condition does affect Black and Brown communities more prevalently than white communities. And that is also, hypertension is also occurring earlier in life among these populations. So another disparity to monitor, to think about looking at your workforce in terms of demographic characteristics and composition. Our budget impact model talks about that as well. But fortunately, all of these data are sad and devastating. Hypertension is preventable and controllable. So let's look at Indiana a little bit. And the next slide, we'll look at the next few slides, we'll look at some Indiana specific data. And you can navigate to this information on your own as well. This link that I just put in the chat will bring us to the BRFIS data set, the Behavioral Risk Factor Surveillance System that your state has organized by key indicators. And if you scroll to page 33 or so, you'll start to find this hypertension data. The BRFIS survey is something that relies on self-reported data. CDC does have a hand in collecting that data, hosting the survey, and then we can look at it at the state level, and then in some cases at metropolitan statistical areas, which we will show you as well. What we're looking at here on this chart, that is, there's a lot of numbers and a lot of small print here. Really, we're looking at about 35% of Indiana adults having been told that they have hypertension. Again, the national rate is nearly 50%. So as a state average, better than the national as a comparison point. But then as you get these slides and take a look on your own, you'll see different percentages in prevalence among different demographic characteristics. And so just curious if you see yourself in this chart, looking at your gender identity, looking at your racial categorization, looking at your age grouping, you should see some of yourself and intersectional qualities kind of in this chart. So again, just something for you to have at your fingertips in terms of data to navigate. The next slide, well, we're still talking about prevalence of hypertension, right? That how many cases exist in the population. And we were able to look at this for Indiana in terms of MSA and MSA specifically. And we know there are some border counties in the state with a couple of other states. So if we look at Indianapolis, again, still lower than the national prevalence. But in the Indianapolis area, we're looking at about 39% hypertension prevalence for adults. And with Fort Wayne and the eastern corner of the state, we're looking at about 42%. Still not higher than the national average, but higher than the state average. And then if you look at your Kentuckiana County, Louisville, we're looking at even higher, 48%, and then the Cincinnati area, 41%. So just curious if anyone is here that is living in or supports employers or organizations in those MMSAs. I'd love to just hear about that in the chat. And also just hear any reactions in terms of national average being nearly 50, your statewide average, and then your MMSA averages. Anything that stands out to you about this map, we just love to hear it in the chat. Or if you if you're representing employer located in those geographies, that would be interesting to know as well. So just give it a moment for you to tap into the chat. And if you're from somewhere not on the map, we apologize that that data is not presented at your county level. But we do, we can at least use some of this data to signify some trends, perhaps. On the next slide, we are going to get into a poll. And so, oh, just kidding. Sorry, not there yet. Not there yet. One more data slide. One more data slide. This slide, we've been talking about prevalence. This slide here, we're talking about age-adjusted deaths from hospitalizations, which are, of course, preventable. Hypertension being a driver of hospitalizations is preventable, and hypertension being a driver of a death is also preventable. If you look to the left of the highlighted column where hypertension has been fluctuating a little bit in terms of its cause of being a leading cause of death, but in the last couple of years, 2020, 2021, we still see that at a rate about 11. And then if you look to the left, you'll see heart disease, which of course is a leading cause of death globally, as Kristen said, and of course in the nation. You'll see those rates. And then if you look to the right, a few columns, you'll see stroke. And again, hypertension being a leading driver of heart disease and stroke. We see all three of these conditions on our leading cause of death list for this state over the last 5 years. And so something that I learned along this hypertension prevention and control journey is that it might not be a condition that's largely on employers' radar because you are often looking at cardiovascular disease. Maybe you're looking at cancer or stroke more so than hypertension. So that's not lost on me. And I guess that's also why we're here, to really point out, that it is preventable and controllable. And thanks for your comments in the chat. I'm seeing a bit come through with blood pressure, so we'll get to that as well. So next two slides, we have a couple of polls. And knowing that prevalence rates are available at the national level, at the state level, at some of the MSA levels, how many of you would be able to answer this question? If you're not, please just let us know you're unsure. But we're really curious if you know what the prevalence of hypertension is in your population. And Sarah, I don't know if we're going to launch a poll, but you're welcome. Yes, we are. Thank you so much. So feel free to respond to the poll so we can see that data pop up. What is the prevalence of hypertension in your population? Less than 20, 20 to 39, 40 to 59, 60% or greater, or unsure? We'll give it a minute just to register to see if folks know. And this is a question we would ask of a healthcare setting or system as well. So this is just a pretty, common question. If you don't know, we want to hear it. How are those responses looking, Sarah? We got people responding.
Yeah, it looks like we have quite a bit responding. So let me end the poll and then it should show everyone the responses.
Great. Thank you for that.
Share results. Okay, can everyone see it?
Yeah. Yeah, unsure about a third of you. That makes sense. And love to see the less than 20. I hope that's not a guess. I hope it But then, yeah, we're seeing, between the 20 and 59% really as what you're thinking your population rate is. Okay, thank you for that. And then just quickly, another quick poll for you, from your current experience, how important is preventing and managing hypertension for your organization? You may think about this and answering this in terms of what have you been doing? If you're doing something, that might signal importance. If it's somewhere lost in the cardiovascular stroke work, we understand that too. And if you've done even more, maybe that signals, somewhat important or very important. So we're just curious, how important is managing this condition for your organization? And honoring the anonymity here, answer with what you think is the reality. And we'll go
Yeah.
through, yeah, great. Got some answers coming in. Let me
Yeah, I was gonna say, it looks like about half of the people on the call have
Okay,
answered.
great. And we'll get into some ways, especially with May kicking off the next section, about how we are hoping to prompt the importance with managing hypertension through some key assessment tools, especially looking at the cost, indirect and direct cost of hypertension on your population. So let's see
Yeah.
what folks are saying. Yeah, thanks for participating in the poll, everybody. Very, we love that. Okay. Appreciate that there's a level of importance with everyone and you showed up at this call for a reason too. So just appreciate it. So this is great. So what we're going to share with you next will hopefully help you even more. And you might even share some great ideas with us to take back to our colleagues. So Meg, I'll kick it over to you to talk about how you went about doing this important work.
Great. Thank you, Michelle, and thank you, everybody, particularly for your participation in those last few polls. I want to start out by making the case that hypertension is obviously an issue for individual employees, but the larger trend that's going on, apropos of that poll that you just took in your answers, is the larger trend is that we're seeing both employees, the workforce, and investors in businesses expecting employers to really prioritize health and well-being, particularly after the COVID pandemic. And I'm sure those are issues and concerns that you're confronting. And some of that activity that they're looking for is offering either value-based insurance design or larger benefits programs to help the employees prevent, manage, and improve population health and well-beings. What's on the screen here and the citations down below is the second annual survey that FTI Consulting did on CEO leadership, asking about a number of issues, particularly following on the pandemic and with the workforce issues. And what they found was that 1 in 3 investors and employees selected as the top priority strengthening employee health and well-being. And so hypertension, as Michelle told us and we walked through just now, is the most common chronic condition among U.S. adults. And it thus presents a workforce issue, but I think it's one that's not only affecting individuals and their employers, but also creates specific business and community risks of well-being and prosperity that can be a really important motivator for putting people first, but also looking at the impact of interventions. So if we go to the next slide, this is where we tried, as Michelle said, was how can we put those risk issues and that business risk, particularly for large self-funded employers, but others, Michelle gave you some insight into this already, stems from the fact from our research that many employees are not aware of their hypertension. And there's a large proportion as well, 3 in 10 employees that don't have their hypertension under control. One of the things, as you responded in the poll, talking about different prevalence rates in your communities or in your organization, those hypertension control rates themselves also vary by industry sector. Depending on the sector, the control rates can be from as low as 48% to 77% of employees having their hypertension under control. Thus, uncontrolled hypertension presents a specific business risk as well. So if we go to the next slide, as we moved forward working with the CDC Foundation and also with the National Forum, we were really trying to put together some core metrics for businesses, for groups, for collaboratives to really understand how this high rate of hypertension prevalence really translates into costs, not just incremental medical costs, but also to productivity costs. So as we heard already, but just to emphasize, about half of US adults with hypertension have at least one other health condition, such as heart disease and stroke, which in and of themselves are associated with higher healthcare costs and worse health outcomes. So when we talk about hypertension, we're not just talking about it in isolation and its treatability and its costs, but also these additional comorbidities and costs. But if we look at the data here, healthcare costs are 44% higher for those with hypertension than those without. And then in addition, undiagnosed and uncontrolled hypertension leads to lost productivity. This is something that oftentimes is not measured or taken into account, which, as we'll see later, has a big impact on employers and on communities. So absenteeism or time away from work is higher for those with hypertension, which really impacts business productivity and community productivity. And the studies, as reported here, with uncontrolled hypertension spend more than double the amount of time away from those with controlled hypertension. So getting it under control in and of itself yields some benefits. But as Michelle had talked about, the good news is hypertension is treatable at reasonable costs, but inaction essentially affects both employers and employees and is a preventable risk. So that, again, is a business case aspect. And so as we step back, how do we go about estimating this preventable business risk across all employers? First, improving chronic conditions like hypertension really requires knowledge, data, and measurement in order to enable employers and others to assess what's the risk for their population. How, if they take action and create a strategic path, how would it affect their workforce and the broader workforce? So that was the mandate we had, which was to identify these costs, but to create new tools, including something called a budget impact model that would collect and aggregate and use all of those data to provide employers clear data on how hypertension affects their workforce and the financial consequence if those risks are unaddressed. So let me go to the next. And Michelle, do you want to lead into this one?
Yeah, that definitely works.
And so I think this is a pretty straightforward one.
Yeah, another poll, right. Thanks, Meg. I lost my Zoom for a minute there, but has anyone ever used a budget impact model before? We previously asked if anyone knew what one was, and then has anyone used one? So this, you might be answering the question 2 in 1 here, but has anyone ever used a budget impact model before? Yes, no, or unsure? We'll see what folks have to say. Thanks, Meg. And the good news about this model is that we've made it relatively easy for you to use. I think you'll be surprised. And then there's even more that you can do with it if you have more nuanced information. So we're really excited to share this with you.
Yeah, and it looks like we got about half of our participants have answered now.
All
So I'm gonna
right,
end the poll and share the results with everyone.
that works. Oh, I love the yeses. Okay, Meg, you might have some feedback, some good feedback coming from our yeses, and even from our nos. But yeah, majority no. So yeah, let's walk through it.
Great. Well, thank you. And if we go, and I'm really excited to see that percentage. And please, in the chat, put your ideas, put your feedback. But if we go to the next slide, we created and developed this budget impact model as a tool, and you see the 4 screens of it. It's live, it's accessible to you. And I have to admit, if I had taken the poll 3 years ago, I would have answered no. But if I had been asked whether I had done multiple regressions that try to control for a lot of factors, I probably would have said yes. What I would like to share about the budget impact model is that it uses easy to access data on your workforce, in your industry, in your sectors, and high level. And built in the background is a tremendous amount of data and information on demographics, on comorbidities, on prevalence, that's all built in there for you already. And so there's actually a very limited amount of data that you have to put in order to get to a very well-functioning dashboard to customize and estimate your costs. So let me give a little bit of background in terms of what we're going to be doing here. So it's going to be estimating costs, both healthcare costs and productivity loss costs, but it's also going to be generating some projections for you. So first of all, when we built this model, we understood that employers have many different departments or functional roles. They may have transportation, they may have retail front ends, they may have finance departments. They also have very different demographic data, as we saw, even across the metropolitan statistical areas across the state. Very different prevalence rates across those communities, very different age and other demographics. And we also find that there are disparities in rates depending on different populations. You may have a younger workforce or an older workforce. So we did try to create an opportunity to put in as many as 5 different workforce types into the model and generate results for each of those, as well as the aggregate. In addition, your healthcare costs may differ for a variety of reasons. And the productivity impact may vary depending, again, on the rate of absenteeism and your wage rates. So there's 4 key steps. They're laid out here, and you can try out the model yourself. But the first is step 1, decide which population you're going to analyze. And it lets you break it down into as many as 5 and generates the results. The second is entering in demographic characteristics. The way the model is set up, you can be as specific and customized as you want. But if you don't know, or you just want to try out the model, there are average demographics that are put in that are, well functioning for a solid workforce. The third is hypertension prevalence data. Again, if you have those numbers, we saw some were less than 20, some were 29 to 39, 20 to 39%, and so on. You can go ahead and enter it, but otherwise there are default values in, and up to 20 different industry categories with their different prevalence rates. And then you can enter your average wages and hours worked, again, as a way to estimate productivity, but there are default values that are in and present there. So let's go to what happens. Let's say we've all entered our data for Indiana, and we customize this for Indiana and the workforce. If you go to the next slide, here's the example of a single dashboard screen. As we develop these tools in partnership, working with Neil, working with Michelle, we asked employers, what data, what metrics do you want to see in a single dashboard that can let you understand the costs that are associated, and not only for average for individual annually, but across your entire workforce. So this is customized to Indiana, and we did overall, and then we did 2 subpopulations. So it's a total number of employees. We used a default of 60% were covered by employer-based insurance, and then we have a prevalence rate, about 35% of people having prevalence rates for hypertension. And that gets you the estimated number of covered employees with hypertension is that 650,000 or so employees. Then we generate 2 numbers. One is what's the additional annual cost for an employee who has hypertension compared to one who doesn't, where that per employee incremental cost is a combination of productivity costs or loss and medical costs. And so the total across that entire workforce is annual costs of over $2 billion. And then you see the numbers for the other employee groups. But let's go to the next one, which we have found in working with employers really starts to motivate the takeaway. What's the impact of this broken down? Left-hand side gives you, again, those basic data on what are the comorbidities. So it shows that that is a factor, and there's more detail there. But we have found the right-hand side really lets employers understand what are the drivers. How much is medical costs, how much is pharmacy, and how much is productivity loss. So you can really understand those annual per employee employer cost breakdowns so that you can get a sense of which of the elements are really driving it. So if we go to the next one, this is what we also have found really provides a sense of, well, what if prevalence continues as it is projected to change over time if we do nothing? And so this looks from 2023 to 2027. What's that impact? But the right-hand side is really giving data and transparency to understand across medical, pharmacy, and productivity loss, what's the cost of standing still? It is the opportunity cost, particularly since, as Michelle said, it's a treatable condition. It is one that could lower costs with investment. So that gets to the next question of, well, what are the kinds of investments that can be done and the kinds of assessments? I want very quickly, in order to get over to Neil, who has a tremendous set of solutions, is to go to the next slide. Something else that you can find on the website is what's called the Claims Analysis Guide, which if we just looked at what's the opportunity cost, why invest, and where to invest. If you look at the Claims Analysis Guide, what we found as we surveyed employers is employers have many different types of access to claims data. Some have data warehouses, some have almost none, but they're all asking the same 3 questions, really. How many of my employees have hypertension? What are the costs in specificity? And then something that we learned through our interviews is people want to know, well, if medication is there for 80% of those with hypertension as the key treatment, are employees actually sticking with their medication? And as a result, is it effective? So these are ways in which you could look at claims data. And if you go to the next slide, here are some framing that we had as to, even if it's a roadmap. So even if you don't have a data warehouse, there are nonetheless issues or information you can request from your health plan or from your benefits design or from others or internally to really get a sense of, if you're thinking about an intervention, if you've put a point solution in place, how can you assess whether it's really making a difference? with that, I think I'll turn it over to Neil as to how you can make a difference.
Thanks, Meg. Great. So super. The Greater Philadelphia Business Coalition on Health, so we're a sister coalition to you. We have 56 employer members representing around 1.5 million covered lives. So most of our members are fairly large self-funded employers. And I've been working with CDC Foundation for several years now on projects. And Michelle had reached out to me and said, what are the employers doing about hypertension? So I said, I really don't know. Let me ask my members. And for the most part, the employer said, gee, we're not really doing anything about hypertension. A few of them had a diabetes vendor and had bought that vendor's hypertension solution. Of course, many employers were doing lifestyle intervention, health coaching kinds of things in general, but very few had a hypertension program in place. And so we were asked by CDC Foundation to think about what would the ideal benefit design look like for employers to start to address the health and economic burdens that Michelle discussed earlier. So if you're convinced that this is something that you can intervene on, and you've used the budget impact model to look at what's the impact economically on my population and what's the prevalence in my population, then it comes down to, okay, what do I do about that? I will say, in many ways, Gloria and I are the yin and yang of getting value for our employer members. I'm all about let's create a healthier workforce and keep people out of the healthcare system. And Gloria's much more about let's hold the healthcare system accountable for reasonable prices and reasonable quality. And we share. I think we are kindred spirits. I'm not saying those are diametrically opposed, but we need to do both, right? We need to help people live a healthier life and identify disease early and keep people out of the healthcare system as much as possible, other than primary care, and then make sure the healthcare system is delivering fair value since we're paying for it. Next slide. So with that preamble, we developed the comprehensive benefit design. This is a PDF document that is available to all of you. I put the link in the chat. We'll also make sure, I think Sarah and Gloria have this link as well, and we'll make sure you all have it as well. So I'm not going to have time to go through everything in the benefit guide in detail, but encourage you, it's not a whole book. It's fairly succinct, but take a look at it and start to develop a strategy to address hypertension. Next slide. So just want to highlight, we came up with 7 strategies. The first one, of course, is supporting healthy lifestyle. Next slide. The second one is really thinking about how are we screening the population, because, as Michelle said, so many people with hypertension don't even know they've got it. And then for those who do have it, it's not controlled and they're not getting routine blood pressure checks. So one of the key messages here is one of the best things we can do is get people into the primary care system, right? I think everybody would agree that when you see a primary care provider, somebody in that office is likely to take your blood pressure at least once on each visit. So if we can get people into the PCP, that's one clear way to get blood pressure read. If you're doing health fairs, if you are doing health risk assessments, make sure that blood pressure is a piece of that. And then most importantly, determine how abnormal findings are being followed up. So if a vendor is doing the biometric measurement, what are they doing when they find an elevated BP? Are they referring that person to a primary care provider? Are they helping that person make an appointment? Are they just saying, hey, you really ought to go see a PCP? And we really need to be proactive in making sure people with elevated blood pressure are getting into the system. Next slide. The third strategy, and Meg started to get into this, is really know your data. So use the budget impact model. If you have access to your claims data, I think it's a great tool to use FTI's claims analysis guide, but also ask your vendors, what is my population prevalence of hypertension? Maybe they're reporting that to you already, maybe they're not. How is that being measured? What do the differences look like by age, by gender? We know that a lot of health plans and other vendors don't have race ethnicity, but to the extent they have it, ask about that. So really start to dig into your data to understand. And then also, we'll talk a little bit more about pharmacotherapy, but given how important it is to control the blood pressure, find out from your health plan if they're collecting information on how many people with a diagnosis of hypertension are on hypertension medications, and then also what's the adherence rate for those medications. So a lot of it is not about doing it all yourself. It's really holding your vendors accountable and asking them to work with you in partnership to address hypertension. Next slide. The fourth strategy, well, this is really part of that same strategy. We just wanted to call your attention to the fact that health plans already are participating, for the most part, in a national reporting system from the National Committee for Quality Assurance called NCQA, and their product is called HEDIS. These are the national rates for the most recently available reported year on how commercial HMOs and PPOs were doing in controlling high blood pressure. So you can see there's a lot of room for improvement. But ask your health plan, what was your most recent HEDIS rate for controlling high blood pressure? It will prove to your health plan you care about hypertension, and you'll see how your health plan compares with the national averages. And then ask them, what are you doing to increase your rate for that measure? Next slide. The fourth strategy, now we're going to get into benefit design, and a few key things I wanted to encourage you to think about. First, even very modest copays or coinsurance on drugs has been shown to significantly reduce adherence. So given that hypertension medications are very cheap, many of them are generic, many of them have very small copays or coinsurance, we would encourage you to waive those copays and coinsurance altogether and do what's called a value-based insurance design. Make those medications accessible at no out-of-pocket cost. The other thing is, after today's webinar, please go back to your health plan, and if you don't already know, ask them, what does our coverage look like for self-monitoring BP cuffs? We know that people who measure their blood pressure at home more frequently are more likely to work harder at controlling their blood pressure through diet, through exercise, and also feeding that information back to their primary care providers, more likely to be adherent to their medications. So very important that you be covering, for people with hypertension, self-monitoring cuffs. And there's a list from the AMA that tells you which cuffs have a good level of validity or reliability. So make sure you're covering not the cheapest cuff, but the most cost-effective blood pressure cuff. And finally, we encourage you to engage pharmacists in reviewing your formulary. Make sure your formulary is adequate to address hypertension. And also, and I know I'm speaking to Gloria's heart on this one, we encourage you to engage pharmacists in medication therapy management or other review for people with hypertension meds. As Michelle said, many of them have comorbidities. Many of them are on multiple medications. They're also taking over-the-counter medications. It's a real risk, and it's potentially interfering with their ability to control their blood pressure. So engage a pharmacist in doing one-on-one medication reviews with the employees at highest risk. Next slide. So other ways you can promote appropriate management, we mentioned engaging pharmacists. Look at the other resources that are already available through your health plans and through your vendors. And you don't always have to reinvent the wheel. Just by asking your vendors, well, are you measuring blood pressure, or what are you doing for the person in our diabetes program who also has hypertension? Hold those vendors accountable for doing a more comprehensive approach to population health management. You don't have to outsource to a hypertension management vendor, but you may want to at least do that on a pilot basis and see if it helps to control uncontrolled blood pressure and reduce costs for people who have significantly elevated blood pressures. Next slide. So other things you can do, there are a lot of resources out there to educate and engage the workforce. So the American Heart Association has lots of great resources, the CDC, and all of these resources are identified in our benefit guide. So not only look at the benefit guide, but also please take a few minutes to look at some of the other resources that are listed there to see where are the other opportunities to get tools or point people with hypertension to good quality information, not Dr. Google. Next slide. Finally, going back to know your data, it's all about measurement. You should have a plan in place for measuring at least annually what impact you're having on hypertension prevalence, hypertension control. Recognize that obesity is closely linked with hypertension, so you can look at weight and obesity prevalence, and really continuous quality improvement. Measure, implement new programs, see if they're working. If not, do something a little bit different. Next slide. So Michelle, I think you're going to wrap up with key takeaways.
Yeah, definitely. And just loving this comment that's in the chat about point solutions and engaging with primary care. So just wanted to respond to that as well, because ultimately that kind of relationship, right, will save a lot of costs down the road in terms of preventable hospitalizations, ED usage, of course, for any condition. So we would always want to recommend definitely encouraging primary care relationship. We know that that's kind of hard won too. So we know that that's not super simple, but it is a key strategy. So yes, Kristen. I think too, that's right, Neil. I like that a lot too. These key takeaways really recap what we were sharing with you. And I think the most salient point is that making an investment and not seeing health and well-being as only cost, being a cost, but making this investment in disease management and prevention, especially for hypertension, does also result in an investment for your business, whether that's cost savings or otherwise. We know that this is a treatable health condition, and we know it's also a hidden business risk. So hopefully these different tools allow you to assess that economic impact, forecast what doing nothing would cost. That's also embedded in the tools. And maybe Gloria will resonate with this, thinking about holding vendors accountable and plans accountable, is that employers really do have the power. There's so much power in what employers do to drive systems, I think. And you do have the power to really prevent and control hypertension. The last thing I want to add to this too is that if you think about planning for interventions in your organization, we can really think about the budget impact model, the claims analysis guide as part of that assessment process, our benefits design guide as part of that strategy prioritization, and then the implementation is really, on your side of the house. But we do know that if we can improve employee health, we're also improving population health, and there is a circumscribed relationship. And so what you're seeing in your community is likely happening in your workforce. So use these tools to assess that, and then guidance to plan your next steps. And then that brings us to the last poll of the slide deck. As a result of this presentation, or just in general, how likely are you to take action on addressing hypertension? Let us know if this has helped spark different action, or if you're, maybe you're continuing to take action. Is hypertension on the radar?
Yeah, it looks like we got a little over 50%, so we'll leave it open for a few more seconds.
All right. And again, Laura put a comment in the chat. We answered that, but yes, the tools are free. They are downloadable. They can work with just knowing your population denominator, the number of employees in your organization. As Meg pointed out, they can help you with a little bit more nuanced outputs if you have a little bit more information. This might also spark you to use employee data for other reasons. So if you don't have that data, this might be a great time to take that step.
The one thing to add too, we welcome your feedback and ideas. Over time, even with this presentation, we customized it significantly to have Indiana data and specifics in it. And so we welcome feedback as to how we could help by customizing it more so that it's even easier to run. Because there are, as we talked about at the beginning, differences across geographies, across areas.
And across industries, right?
Yep.
I mean, that's the biggest, yep. So that poll says very likely, right? Oh, yay, thanks everyone. Seeing likely at 57%, very likely at 29%. And would be remiss if I did not mention the comment that was put in about any expansion on getting chronic conditions covered. So thank you for that too, Michael Kaufman. And I think our last slide, just really want to wrap this up and remind folks of what we put in the chat already. There are multiple tools and supporting documents that can really help make the business case for hypertension control. We do have a National Hypertension Control Roundtable that we convene with CDC and clinical providers looking for more employer participation and feedback. And we welcome you to visit the website, check that out, and then also find all the business case tools right there. And if you need anything else, we're here for you. Your forum team knows how to get a hold of us. But on the next slide, we just got our contact info, and there it is. Thank you so much.
Thank you so much. I do have a question for you. Would love your thoughts on it. I know there's some questions that have been put in. So in Indiana, most of the self-funded employers, over 70%, have high deductible health plans. And so that's where that IRS question stemmed from. Most of the country sits around 70% or 50% or less. The average is around 50%, but we are, I think, the second highest state in the country with high deductible health plans. And so then we have to charge, because of that, we have to charge patients first dollar. So you mentioned pharmacists, point solutions. Just wondering if you had any other thoughts, since that is unique to our market.
Neil, of course I look at you.
No, I think it's a good question. Now, just going back to the point about the IRS list, there are, like blood pressure cuffs are on that list. There are a couple of cardiovascular drugs that are used in the treatment of hypertension as well. So not a perfect solution by any means. Nothing's immediately coming to mind there.
I think one idea that you mentioned, I think that would work here, is holding everyone accountable. So if you have an on-site clinic, make hypertension, patients should achieve their therapeutic goal, their hypertension goal, as a performance guarantee, if you will, in the on-site clinic. That way they're measuring it, and then there's some accountability there, maybe with the health plans, providers. That could be an option that employers have partners with.
Mm-hmm.
Yeah, Gloria, one of the things we've been exploring a little bit is the health plans, because of that HEDIS measurement, they know which providers are doing a better job with controlling high blood pressure. We're exploring, I don't think we're going to get very far so far, but maybe you could think of ways to get that data into the public realm. Like
Great idea.
health
Really,
plans.
I can look them all up. I know the star
Right.
rating for insurance companies. Yep, we'll do
Yep.
that. Thank you. That's a great idea.
I think the other related thing is we have seen, as part of this initiative, we had David Hines from Nashville Public Schools and also Jake Fleitz from Paychex. And a couple of things that they mentioned was this idea of just having everyone be aware that there was a concern and that there was activity on the part of employers in and of itself. Was something that made everybody aware that there were treatments available and that the employer cared about them. The second part is that there was some engagement in community-wide initiatives to create that awareness and some of that support. But then I think it was also kind of on that accountability note of really trying to track what exactly was being done and what was being effective. In terms of getting it from uncontrolled to controlled hypertension was one of the areas. So looking at how you get that treatability addressed was something that they each had done. So those might be some additional ideas. The other thing is looking at, if it matters, is looking at what's the return. One of the things Jake Fleitz had mentioned in particular is that they had a value of investment that was unanticipated, is that their consumer satisfaction actually increased as employees felt more, taken care of. And as a result, took better care of the customers as well as themselves. So again, just some ideas that could go toward the messaging and how to keep everyone engaged.
Excellent. Well, thank you, everyone. I know we are a few minutes over, so appreciate your time and all of your expertise, especially for Michelle, Meg, and Neil. I think you've given us a lot to talk about, and I feel like, Gloria, we're going to have to take this back as a forum and maybe debrief on, what our next steps are, if any, and how we can help our employers that are part of the forum as well. So thank you all for joining us. Lots of great discussion, data, and a new model for us all to check out. Before everyone departs today, I feel like this discussion leads well into this slide here. So for those of you who are forum members and aren't aware, the National Association of Worksite Health Centers is having their annual forum here in Indianapolis. That is happening August 22nd through the 23rd, and the forum is partnering with them. And so we have a discounted code for our forum members. If you would like access to that code, please reach out to Sarah Oddie. Her email is on the screen and also posted on our website to get that. So when you register, you get a reduced rate. It will be held at the Conrad in Indianapolis. Many of our forum members will sit on panels and talk more about what they're doing in the space of on-site, near-site, and even some virtual health centers. So I think it's just so cool that we're having this meeting here in Indianapolis, that we're partnering with the National Association of Worksite Health Centers. And I know for a fact that probably this hypertension discussion will likely come up there as well, since many of the worksite centers are managing some of these types of chronic conditions or just overall populations with a high prevalence of hypertension, especially as was pointed out in pockets here in Indiana. So please make sure you mark your calendars, register, get that discount code from Sarah. Thank you again to all of our speakers and for everyone attending today, and find all of that information on the website. Also, thank you, Sarah, for moving this slide ahead. If you are planning on coming to our fall all stakeholder meeting that will be in November, the meeting date has been changed from November 7th to the 12th. Same location, Indiana Landmarks, but date change from the 7th to the 12th. So please make sure you update your calendars. More information coming on that soon. So thank you again for attending. Gloria, Sarah, please jump in if I've forgotten anything. And again, huge thanks to Michelle, Meg, and Neil for sharing these really valuable insights with us.
Yep. Thank you to our speakers, and thank you everyone for attending. We'll see you soon.